Greetings from Team Indian Medical Association. Our project Digital IMA and a weekly webcast every Thursday 3 to 4 p.m. This we are continuing for the last many months, and today in our new series of webcasts we have two important things. One is we have our National President Dr. S.S. Agarwal with us, and who will also be initially 15 minutes. We will have his address as a address to the nation, to the IMA members all across the country. And after that, all three of us, Dr. S.S. Agarwal, myself, and Dr. V.K. Monga, we will be interacting on an important subject, the care of the elderly. Why we have chosen this subject is because in the forthcoming IMA CGP event, which is occurring on Sunday 24th, we are honoring the oldest practicing GP in the country and the oldest non-practicing GP of the country. And we thought that we need to create a group. We need to have all our people who are oldest old, that means who are 80 plus, and we should be able to talk to them, take their advice, make them as an advisors. Also, this year we are starting our centenary conference year celebration, because the first conference in the country, I'm not talking about the installation of Indian Medical Association, I'm talking about the first medical conference in the country in November this year will complete 99 years, and we will start a full year of centenary events, conferences, participations. Indian Medical Association was born in 1928. And this year we will also be celebrating and honoring all doctors who were born before IMA. IMA was born in 1928, so all those doctors in the country whose birth is before 1928, we are trying to gather their information, come out with a directory, and during the year in one of the events we are going to honor them. That means one of the focus of our new team IMA this year will be on elderly care. When I talk about elderly care, it means 60 plus, some people say 65 plus, but for us we will focus on 80 plus, the population called oldest old. Normally 8% of the population is elderly, and out of these 8%, approximately 10% of them would be the oldest old. And if I go back to the definition of oldest old, in the city of Delhi alone, we should have had 400 doctors practicing who are 80 plus. But we made 2 attempts in the last 5 years, and we wanted, on behalf of Delhi Medical Association, to honor all oldest old people. We could not get more than 15. And therefore the issue came that being a medical doctor is injurious to health. That means doctor on an average die 10 years younger than a non-doctor. A matter of debate. We are not here to debate, but let's, before we go back to our main subject of elderly care, let's have a introductory message to the nation, to all our IMA members, from our President, Dr. S.S. Agarwal.
नमस्कार। जैसा कि आप सभी को मालूम है, इंडियन मेडिकल एसोसिएशन देश की एक सबसे बड़ी प्रोफेशनल ऑर्गेनाइजेशन है, जो कि एकमात्र प्रतिनिधि संस्था है क्वालिफाइड मेडिकल प्रैक्टिशनर्स ऑफ मॉडर्न मेडिसिन। इसके 2,50,000 से ज़्यादा लाइफ मेंबर हैं, और अपना ये 30 राज्य शाखाओं के साथ 1700 लोकल ब्रांचों के द्वारा अपनी सेवाएं पूरे के पूरे कंट्री के अंदर दे रहा है। यही नहीं, वर्ल्ड मेडिकल एसोसिएशन के साथ होकर यह पूरे विश्व के अंदर भी अपनी उपस्थिति दर्ज करा चुका है। इंडियन मेडिकल एसोसिएशन पूरे देश के अंदर ऐसी संस्था है जो कि अपने मेंबर्स के हित के साथ साथ कम्युनिटी और कंट्री के हित भी बराबर देखते हैं, और कम्युनिटी सर्विसेज के अंदर यही केवल एक प्रोफेशनल बॉडी है जो कि कहीं भी किसी भी प्रकार की कम्युनिटी सर्विसेज की आवश्यकता पड़ी है, चाहे विपदा के टाइम में और चाहे नॉर्मल टाइम के अंदर अपनी पूर्ण रूप से सेवाएं समर्पित करी। इंडियन मेडिकल एसोसिएशन अपने केवल जो मेडिकल मेंबर्स हैं उनका ही नहीं, अगर कोई भी प्रैक्टिशनर्स जो कि मॉडर्न मेडिसिन का है उसके ऊपर किसी भी प्रकार का विपत्ति या किसी प्रकार की आवश्यकता की जरूरत पड़ी है तो वह मेंबरशिप को नहीं देखकर उसकी मदद के लिए और उसको किसी भी प्रकार से टॉर्शन नहीं हो उसके लिए वो आगे रही। मैं इसको इस तरीके से भी कह सकता हूं कि एक तरीके से इंडियन मेडिकल एसोसिएशन जो देश की स्वास्थ्य सेवाएं हैं उसका गवर्नमेंट के साथ साथ स्वास्थ्य सेवाओं की कस्टोडियन है। वह आज सरकार को और सभी जो हेल्थ केयर डिलीवरी सिस्टम के स्टेक होल्डर हैं उनको ये बात माननी पड़ेगी कि अगर हम कंट्री के अंदर हेल्थ केयर डिलीवरी सिस्टम को ठीक करना चाहते हैं, इम्प्रूव करना चाहते हैं तो वह इंडियन मेडिकल एसोसिएशन के बिना नहीं कर सकते हैं। इंडियन मेडिकल एसोसिएशन पूरे जिसकी की उपस्थिति इन 1700 ब्रांचों के द्वारा नॉर्थ ईस्ट से लेकर सुदूर पश्चिम के अंदर और कच्छ के रेगिस्तान और जो नक्सलाइट एरिया हैं वहाँ से आतंकवादी एरियो से लेकर और आदिवासी एरियो के अंदर पूर्ण रूप से इसकी उपस्थिति रही और इस उपस्थिति के कारण ही आज जिस प्रकार की स्वास्थ्य सेवाओं के अंदर कमी आई है, किस प्रकार से पूरे के पूरे सरकार, डॉक्टर, जनता, पेशेंट इनके बीच के अंदर जो एक आपसी विश्वास की कमी आई है उस कमी को इंडियन मेडिकल एसोसिएशन सेतु का काम कर उसको पूरा करना चाहती है, जिससे आपस के अंदर मरीज, डॉक्टर और सरकार इन तीनों के बीच के अंदर एक सामंजस्य हो, एक विश्वास हो। इसके अलावा भी जो सरकार और हमारी जो पॉलिसीज हैं उसके अंदर जो एक प्रकार के मतभेद उत्पन्न हो गए हैं और उसके कारण जो स्वास्थ्य सेवाएं हैं वो इम्प्रूव नहीं हो पा रही हैं, उसके अंदर भी सरकार और इंडियन मेडिकल एसोसिएशन आपस में एक विश्वास का रिश्ता कायम हो और उस विश्वास के रिश्ते से हम अपने देश की स्वास्थ्य सेवाओं को उन्नत बना सकें। इसके ऊपर मुख्य रूप से हमारा प्रथम मुख्य उद्देश्य और एजेंडा रहेगा। मैं अपने सभी स्टेट के जो ब्रांचें हैं उनको ये आग्रह करूंगा कि वह एक कॉर्डियल एटमॉस्फेयर सरकार के साथ बनाएं, जिससे कि हम अपने कंसर्न जो इश्यूज हैं उनको सरकार के सामने रख सकें और उसका आपस में सामंजस्य मिलकर हम देश की स्वास्थ्य सेवाओं को, प्रदेश की स्वास्थ्य सेवाओं को, अपने जिले की स्वास्थ्य सेवाओं को एक उन्नत रूप से आगे बढ़ा सकें। आज जितने भी नेशनल हेल्थ प्रोग्राम्स हैं, हम चाहते हैं कि इंडियन मेडिकल एसोसिएशन उसके अंदर सरकार के साथ भागीदारी बने। हम अपना आपको सरकार को के साथ हाथ मिलाना चाहते हैं, अपने हाथ आगे बढ़ा रहे हैं कि जो नेशनल हेल्थ प्रोग्राम है वो केवल एक सरकारी प्रोग्राम बनकर नहीं रहे, वह प्रोग्राम उस अंतिम व्यक्ति तक जा पाए जिसकी की सरकार टारगेट कर रही है। आज जितने भी राष्ट्रीय स्वास्थ्य कार्यक्रम हैं वो केवल एक सरकारी कार्यक्रम बन के रह गए हैं, उनके अंदर जन भागीदारी नहीं है। आज करीब करीब 70% स्वास्थ्य सेवाओं जो प्राइवेट सेक्टर उपलब्ध करा रहा है और केवल थोड़ी सी 30% सेवाएं ही गवर्नमेंट दे पा रही हैं। जब तक हम इस 70% जो प्राइवेट सेक्टर है उसको हम बढ़ाएंगे नहीं, उसको हम प्रोटेक्शन नहीं देंगे, तो देश की स्वास्थ्य व्यवस्थाएं दुरुस्त नहीं हो सकती हैं। और इंडियन मेडिकल एसोसिएशन इस काम के अंदर सरकार के साथ हाथ से हाथ मिलाने के लिए तैयार है। मैं सरकार को और अपने सब साथियों को ये बात बता देना चाहता हूं कि आप जो हेल्थ केयर डिलीवरी सिस्टम है उसके जो मेजर स्टेक होल्डर हैं उनके इश्यूज को अगर किसी भी तरीके से एड्रेस सरकार और वहाँ का प्रशासन नहीं करेगा तो आप अच्छी स्वास्थ्य सेवाओं की उम्मीद नहीं कर सकते हैं। आपको उन इश्यूओं को एड्रेस करना पड़ेगा और जो इश्यूज हैं वो आज सबको मालूम है। केवल अपन रूल्स रेगुलेशंस और एक्ट बना दें तो उसके कारण व्यक्ति की क्षमताओं का कम हो जाती है और वह उस पूरी अपनी क्षमताओं के साथ काम नहीं कर पाता है। इसलिए जितने भी रूल्स एक्ट और रेगुलेशन हैं वो बहुत कम होने चाहिए, वो रेस्ट्रिक्टेड रहने चाहिए, जो कि एक गाइडलाइंस के अनुसार हों। वह इस तरीके से नहीं हो जिससे कि वह अपना फ्रीली काम नहीं कर पाए। आज जिस प्रकार का पूरे देश के अंदर सरकार जो चिकित्सकों के प्रतिष्ठान हैं उनके ऊपर हिंसा, लूटपाट, गाली गलौज, इस तरीके का जो असाल्ट का जो वातावरण उनके एस्टेब्लिशमेंट और डॉक्टरों के प्रति है उसकी तरफ वह काम नहीं कर रही है। इसके कारण क्या हो रहा है, असामाजिक तत्व इस प्रकार की गतिविधियां बहुत ज्यादा कर रहे हैं। जब तक उन असामाजिक तत्वों को असामाजिक तत्वों के सामने सरकार ने समर्पण कर रखा है, मैं ये बात बताऊंगा, उनको किसी भी तरीके से रेस्ट्रिक्ट नहीं कर रही। सरकार को इन सब असामाजिक तत्वों को रेस्ट्रिक्ट करना पड़ेगा। असाल्ट जो हो रहा है डॉक्टर और डॉक्टरों के प्रतिष्ठानों के ऊपर, उसको सख्ती से रोकना पड़ेगा। और उनको जब सख्ती से रोकेंगे तो बिना भय के अगर चिकित्सक अपना काम कर पाएंगे, स्वास्थ्य कर्मी अपना काम कर पाएंगे, तो वह अपनी पूरी की पूरी क्षमता से और स्वास्थ्य सेवाओं को बेहतर बना पाएंगे। इसी प्रकार के 3-4 जो पॉइंट हैं, इश्यूज हैं, जिसके अंदर सबसे पहला असाल्ट ऑन डॉक्टर्स ही है। दूसरा जिस प्रकार का है क्लिनिकल एस्टेब्लिशमेंट एक्ट। क्लिनिकल एस्टेब्लिशमेंट एक्ट में जो सरकार की मंशा है वह मंशा है कि हेल्थ सर्विसेज, चिकित्सा हर आम व्यक्ति को इजीली एक्सेसिबल हो, अफोर्डेबल हो, विद क्वालिटी हो। लेकिन मैं आज फिर सरकार को ये बता देना चाहता हूं कि इस क्लिनिकल एस्टेब्लिशमेंट एक्ट से जो ये तीनों सरकार की मंशा है वह पूरी नहीं होगी, बने इसके कॉन्ट्रारी जाएंगे। न तो हमको सर्विसेज इजीली एक्सेसिबल हो पाएंगी, न वो अफोर्डेबल रह पाएंगी, और क्वालिटी केवल वही दे पाएगा जो कि इन इंस्पेक्टर्स का या उनका अपना महीना भत्ता देगा। इसके अलावा उसकी ही क्वालिटी अच्छी मान ली जाएगी। जो बिल्कुल ईमानदारी से या बिना इस प्रकार से देना पाते हैं उनकी वो क्वालिटी को उनके मर्जी के ऊपर रहेगी कि वह किस प्रकार की देते हैं। इसके लिए हमने सरकार को बताया था कि वह एक क्रेडिटेशन प्रोसेस चालू करे, जिसके अंदर वह एक नॉमिनल फीस में हर एस्टेब्लिशमेंट का एक क्रेडिटेशन करे, और एक क्रेडिटेशन से जो रिसीव करने वाला है उसको अपने आप मालूम हो जाएगा कि मेरे को कौन सी सेवाओं की आवश्यकता है और वह सेवाएं कितनी गुणवत्ता युक्त हैं और यहाँ पर इस प्रतिष्ठान में कौन सी सेवाएं मिल रही हैं। ये जब उसका जो आज बता रहे हैं कि साहब ये एनएबीएच होती है और उसके लिए बहुत भारी पैसे हैं, उसके लिए सरकार पैसे देवे। उसके लिए एस्टेब्लिशमेंट, अगर क्लिनिकल एस्टेब्लिशमेंट चालू कर रही है तो उसका खर्चा कौन उठाएगा? सरकार उठा रही है। इसी प्रकार इसका भी पूरा का पूरा इंफ्रास्ट्रक्चर सिस्टम बना के और उसका उठाए। केवल नॉमिनल फीस प्रतिष्ठानों से लेवे जो अपना इस प्रकार का एक्रेडिटेशन कराना चाहते हैं। अगर एक्रेडिटेशन कराएंगे तो उसकी गुणवत्ता का भी पूरा का पूरा मालूम पड़ेगा और वो सर्विसेज के अंदर भी सुधार होएगा। जबकि क्लिनिकल एस्टेब्लिशमेंट एक्ट के अंदर केवल एक इंस्पेक्टर राज और करप्शन को बढ़ावा मिलेगा, इसके अलावा नहीं हो सकता है। इसके अंदर और भी जो प्रोविजंस हैं वो प्रोविजंस इस प्रकार के हैं जो कि हमने सरकार को ही बताए हैं और हर जगह हमने इसके बारे के अंदर बताया है कि वह किसी भी तरीके से उपयुक्त नहीं है। जैसे कि पुलिस का इंटरफेयर, जैसे कि स्टेबलाइजेशन क्लॉज, ये सब क्लॉज जो हैं वो किसी भी तरीके से नहीं होने चाहिए। इस क्लिनिकल एस्टेब्लिशमेंट एक्ट के द्वारा क्वैकरी कहीं भी नहीं रुक रही है। सरकार की जो मंशा है कि मैं क्वैकरी को कमती करें, क्लिनिकल एस्टेब्लिशमेंट एक्ट के बाद क्वैकरी को बढ़ाना और ज़्यादा हो जाएगा। और जो क्वालिफाइड डॉक्टर्स हैं जिन्होंने कि अपना रजिस्ट्रेशन करवा लिया है वह केवल इससे ग्रसित होंगे। जो ऑलरेडी क्वैकरी कर रहे हैं उनके ऊपर किसी भी प्रकार से लगाम नहीं लगेगी, क्योंकि इसके अंदर प्रोसिक्यूशन नाम की चीज़ नहीं है। क्वालिफाइड डॉक्टर्स रजिस्ट्रेशन नहीं करवाते हैं और अनक्वालिफाइड रजिस्ट्रेशन नहीं करवाते हैं, दोनों का समान पेनल्टी है। उसके अंदर किसी भी प्रकार से अलग अलग पेनल्टी नहीं है। इसका प्रोविजन अलग होना चाहिए और जो अनक्वालिफाइड अगर किसी भी प्रकार की ये प्रैक्टिस करते हैं तो उनके ऊपर प्रोसिक्यूशन प्रोसेस चालू होना चाहिए। इसके अंदर और भी बहुत सारे मुद्दे हैं, लेकिन एंटी क्वैकरी बिल सरकार को लाना चाहिए जिसके कारण कि हम अपने गुणवत्ता की सर्विसेज रूरल एरिया में और रिमोट एरिया के अंदर भी समान रूप से दे सकें। आपको मालूम है कि किस प्रकार से पीसीपीएनडीटी एक्ट के अंदर प्रताड़ित किया हुआ है और पीसीपीएनडीटी एक्ट को भी हमको पूर्ण रूप से मुख्य रूप से बदलाव करने पड़ेंगे, क्योंकि इसको लगे हुए इतने साल हो गए लेकिन सेक्स रेशो के अंदर एप्रिसिएबल चेंज नहीं आया है, बल्कि वो बिगड़ता चले गया है। हमको देखना है कि इसका रिव्यू करें कि इसके अंदर कमियां कहाँ रह गई है। केवल इस पूरे के पूरे सेक्स सिलेक्शन को डॉक्टरों को ऊपर थोप देना कि उनके कारण ये ठीक नहीं हुआ है, यह किसी भी तरीके से उचित नहीं है। सरकार अपनी अकर्मण्यता छिपाते हुए ये सारा का सारा दोष चिकित्सकों के ऊपर डाल रही है, जो कि बिल्कुल भी उचित नहीं है। सरकार को इस एक्ट को पूरा का पूरा रिव्यू करना चाहिए। इसके अंदर जो प्रोविजन है वो उसको ठीक करने चाहिए, क्योंकि केवल 17F जो एक प्रोविजन है 17F फार्म, क्या 17F फार्म बिल्कुल ठीक भर देने से, पूरा भर देने से सेक्स सिलेक्शन रुक जाएगा? जो कि सरकार का पूरा एक तरीके से जोर इसी के ऊपर है कि 17F फार्म अगर पूरा भर दिया तो सेक्स सिलेक्शन ठीक हो जाएगा। यानी ये इस तरीके की बराबर मेडिकल प्रोफेशनल्स ही नहीं, सब लोग बाग ये कह रहे हैं कि इस एक्ट के द्वारा हमको किसी भी प्रकार का सेक्स सिलेक्शन जो कि कर रहे हैं उनसे उनका कमी नहीं हुई है। इंडियन मेडिकल एसोसिएशन ये चाहती है कि जो भी सेक्स सिलेक्शन करे उसको कठोर से कठोर दंड दिया जाए, उसके ऊपर किसी भी प्रकार की डिफरेंस ऑफ ओपिनियन नहीं है और हम उसके समर्थन में भी नहीं है। लेकिन निश्चित तौर के ऊपर जो सेक्स सिलेक्शन नहीं कर रहे हैं, केवल उनकी कोई टेक्निकल क्लैरिकल कोई गलती हुई है उसके ऊपर उनका प्रोसिक्यूशन एट द सेम, जिसने कि सेक्स सिलेक्शन किया है उसके बराबर प्रोसिक्यूशन हुए, ये किसी भी तरीके से उचित भी नहीं है और ये बर्दाश्त भी नहीं किया जाएगा। इंडियन मेडिकल एसोसिएशन इसके पूरे के पूरे विरोध के अंदर है।
So let's now take a couple of points on the elderly care. Just to show you again that on emedinexus.com you can directly go. It's a Facebook-like presentation where you can directly listen to the webcast. You can also pose your questions in that, and we will be answering you live in that. We already have 9 comments, and Dr. Rajinder Kaul is asking again her internet. She says my internet speed is okay. Just try to see why deceptions are coming in her computer with that. So our topic for today, after we have got the message from the national president, will be care of the elderly. And in the next 40 minutes, we are trying to come back to certain basic consensus on certain basic points on elderly care. Now remember that every doctor here who is listening to our webcast should be able to open an elderly clinic. Elderly care is a specialized care. It needs a special concern. And today, we cannot provide geriatricians across the India to look after the geriatric population. We have pediatricians, but geriatricians no. Therefore, every family physician and every physician must know how to take care of a geriatric patient. We need minimum 20 times more geriatric specialists if we really want to provide a geriatric specialist care, which is not possible. Therefore, what IMA recommends is very clearly that every family physician must know 1 point each on whatever we are discussing now. And this we will make it as a guideline, as a white paper, which will be there on our IMA website. And everybody should be able to start a geriatric clinic or at least provide geriatric care to their patients after listening to the same thing. I'm just enumerating where we are going to have a consensus by the end of this 40 minutes. One is lifestyle of the elderly. We'll focus one line on exercise, one line on tobacco, aspirin prophylaxis and elderly immunization. Then we'll come back to cancer screening in the elderly group. Then we'll come back to cardiovascular disease prevention, whether it is blood pressure, lipid or abdominal aorta measurement. Then we'll talk about diabetes. An important thing will come back to the functional status of an elderly, psychosocial status, cognitive functions, all the 5 cognitive functions, and then we'll come back to the role of vitamin D, osteoporosis, then vision changes, hearing changes. Is there any role of multivitamins, prevention of falls and mobility, incontinence? Is there any role of Viagra? Obviously not in the oldest old, but yes, in the elderly 60 plus. Viagra-like drugs, can they use, how safe they are, the role of polypharmacy on some guidelines, and then end-of-life issues. The last 5 minutes we are going to talk about end-of-life issues, advanced directives, we'll talk about will, we'll talk about certain reverse mortgage, all those things which are available for the elderly population. And remember, the focus of every GP should be prevention of fall, prevention of dementia, taking care of, and there's a big project coming all over the world, Forget Me Not, under which care of the dementia is being taken care of, and then prevention and care of incontinence and all the end-of-life issues with that. So it's open. I'm going to ask exercise. What if a person comes to you with 80-year-old, what suggestion you give him? Do you ask him to run?
Yes, definitely. I mean, light exercises should be taken up on a daily basis, and it should be regular. I mean, if it is the winter, extreme winter, it can be done indoors also, and it can be a little PT type of a thing.
So,
and if somebody can do yoga, yoga is very good.
Walking does not mean peak sun,
Yeah.
and walking also does not mean peak winter.
Extreme winter, yes.
So that whenever you find 9 o'clock, 8 o'clock, 10 o'clock, whenever you find
Whatever.
comfortable
Yeah.
and there is no smog, you should be able to walk.
Wow.
Any other thing you want to add?
उसके अंदर वो अपनी क्षमता के अनुसार अवश्य आइसोमेट्रिक जो एक्सरसाइज हैं वो करें, जिसके कारण, और दूसरा जो है वो एक्सरसाइज के साथ साथ मसाज, जिससे कि जो बॉडी के अंदर उसकी टॉनिसिटी जो है ना वो बराबर।
So the message is, if I have to have a one-line answer for exercise as a protocol, move and move. It's not necessary for you to run. It's not necessary move and move. Wherever you get an opportunity, make them move minimum 3 times in a day. All elderly people should not be staying on the bed, because if you make them stay on the bed, they will never get up. So make them move and involve massage. The body massage, which produces, remember, massage produces VIP, vasoactive intestinal polypeptidase, which is the strongest vasodilator in the body. Therefore, if you want to produce a VIP hormone, use the massage purposes for all people who are elderly. That's one. Two, tobacco. Your type of tobacco. No tobacco.
Yeah.
नहीं, टोबैको तो किसी भी फॉर्म में केवल एल्डरली को ही नहीं, किसी को भी
So, but
होना चाहिए।
suppose you find a person who is 95 plus and he is using tobacco, and he says, I enjoy my tobacco, I don't want to, if I have crossed 95 on tobacco.
If tobacco has not done any harm in 95 years, it won't do in another 5 years. I think
So the answer is that those elderly who are not tobacco users should not start. Those who are taking tobacco should reduce. And if they cannot stop, it has to be under limit. Medical advice in any way will be to stop tobacco. But there will be circumstantial evidences where situations where you may have to allow tobacco in certain cases. Specifically, for example, if a person has lung cancer and is not going to survive, his survival time is less than 6 months. What's the idea of stopping tobacco at that
नहीं
particular?
नहीं, ये तो
What about-
आखिरी इच्छा हो गई सब उनकी।
Yes.
तो आखिरी इच्छा तो सभी जगह जो है ना,
Aspirin
वो अलग होती है।
prophylaxis. As third is aspirin prophylaxis.
I think, nowadays everybody is advocating every 60+ person should take aspirin as a prophylaxis.
So there is a British protocol, and the British protocol, when they talk about polypharmacy, they are talking about use of aspirin 75 milligram to every percent. But in India, our standing is still clear because of a potential GI bleed and other thing, is that if you are a high risk, you need aspirin prophylaxis. Immunizations for people who are 65 plus.
इम्यूनाइजेशन उसके अंदर जो इमीडिएटली अगर थ्रेट है, जो कि अभी आया है फ्लू वगैरह जो कि आजकल सीजनल आ रहे हैं, उसके अंदर उनको अवश्य इम्यूनाइजेशन करा लेना चाहिए।
So for the oldest old and for the elderly, we have 4 immunizations which are to be considered by every GP. One is tetanus toxoid every 10 years, flu every year. All people who are above the age of 65 must be given an option for flu vaccine once in a year, pneumonia vaccine once for life. Once you have crossed the age of 65, they should be given 1 shot of pneumonia. And today now we are talking about pneumo 13 and pneumo 23. At a 6 months interval, we should give both of them. So start with pneumo 13 and then pneumo 23. Give them 2 shots and then you don't need to give it again. And then herpes zoster is an option. Internationally, they are talking about herpes zoster vaccination to 60 plus in every case. In India, you still have an option because most of us have suffered from chicken pox in the childhood. But yes, zoster is one of the possibility you should discuss with your patients. When it comes to cancer screening,
it should be given to only the risky person or high
yes,
risk
that's
person.
what I'm saying. In India, in US they talk about to everybody, but India we talk about if once you have already got a chicken pox in the childhood, you may not be needing herpes zoster. Therefore, herpes zoster is to be debated, but you should consider as a part of debate, do my patient need a herpes zoster vaccine or not? When it comes to cancer screening in 65 plus, we have 5 cancers to be considered. One is prostate, second is colorectal, may not be that common in India, breast cancer, cervical cancer, and lung cancer. Any advice?
I think you have all the points needed.
But
I will go for these checkups every year
You will
after
go
the age
for
of
this.
80 years.
prostate cancer also you should increase, including for the male.
That's what you said.
I already said.
Yes.
Not
Yeah, that's what you said. Yeah.
लेकिन after 80 it is obvious कि but if there is no need every year, if there is high risk in particularly or the
So the IMA policy is high risk. If you are high risk patients, say for example, screening all over the world, the international consensus now is that no screening for cancer as a routine. because it does not help you. It will make more biopsies, it will cause more harm to the patient, and then no screening if the lifespan in any way is low. If you find a person's lifespan is less than 2 years or 1 year, what's the purpose of looking for another cancer in that particular case? But yes, in all high-risk individuals, we need prostate screening by digital rectal examination, transrectal ultrasound, or by PSA density and PSA velocity. Colorectal is, in the US, they talk about 50 to 75 years of age. They want an annual colonoscopy, but in India, no, not necessary. But then if there is a high risk, yes. Breast, yes, definitely mammography and the role of self-breast examination comes. Cervical, yes, less than 65 years of age. If the person has not taken a HPV vaccine, we need so whenever you go for a gynae checkup in any way, they will be doing a cervical screening. Lung cancer for those who have been consuming cigarettes and for the last 15 years, they should go for a low radiation CT scan, spiral CT scan to look for a lung cancer. Yes. Now we come back to 3 screenings in cardiovascular system, and that's blood pressure, lipids, and measurement of abdominal aorta. Any tip? You will not comment.
I don't think lipid regular screening is necessary.
So lipid,
but if it is done in the once, and if find there is a discrepancy between the what is normally required and what is not normally, then for the coming to the normal, it requires regular monitoring.
so blood pressure once in a year, because you have a isolated systolic hypertension which is common in this population, and the target will be different than in the we may not have to keep a target of 110/70 or 120/80. Little bit higher targets in the elderly is fine. Lipid, if normal, every 5 years. Sugar, if normal, every 3 years. You may not go for an annual, but yes, at the age of 60, it is better to know the lipid profile. Whether to treat it or not is a separate controversy, because if the person hasn't got any disease by the age of 65, do you need to treat a abnormal lipid in the age group of elderly or not? But yes, definitely, you need to screen once, and if it is normal, once in 5 years for lipids, and once in 3 years for the diabetes. As far as abdominal aorta is concerned, that's a new screening methodology, that whenever you're going for abdominal ultrasound or an echo, cardiac echo and abdominal ultrasound also measure the abdominal aorta. And that abdominal aorta need to be measured to rule out abdominal aorta aneurysm, which is not uncommon in a atherosclerotic population in the country. So whenever you're going for an ultrasound of the abdomen or an echo, ask for also to check abdominal aorta for an aneurysm with that.
How many this abdominal aorta?
I see one or twice. I see 1 or 2 in a year, but not in the stage of operable. But I do see one. Then I do an echo, and I do it as a part of routine. In every person between the age of 65 and 75, I make it a habit to measure the abdominal aorta in every patient when I'm undergoing an echocardiography, and we do see unsuspected asymptomatic abdominal aneurysm. Only one in the last 10 years I've been able to refer in for surgery. Most of them need to be watched, because sudden death in such cases is very common as a part of dissection with that. Now we come back to cognitive function. The concept is forget me not. I'm going to spend a couple of minutes here, and I'm going to couple of minutes here, and I'm going to check whether Dr. V.K. Monga has any dementia or not. अभी मैंने क्या पढ़ाया था आपका?
अभी आपने कैंसर के क्या-क्या लक्षण?
So this is called immediate memory. This is called immediate memory. Immediate memory is that whatever you are talking now, and if you get disrupted, say for example when we are talking, suddenly a phone comes, and then you start asking, मैं क्या पढ़ा रहा था? That's an immediate memory, which is linked to cognitive MCI, that is minimal cognitive impairment, and that is also linked to vitamin B12 deficiency, also to excessive of alcohol, but it is also a sign of early dementia. The first to go will be the immediate memory. So one is immediate memory. What is 100 minus 7?
93.
93 minus 7.
86.
That is called calculation. That's the second function of cognitive function is calculation, and that's called 100 minus 7 formula. Go on reducing 100 minus 7, it becomes a different thing. And tell me, which one is nearer, this phone or this phone?
What is it, this one?
This is called spatial disorientation. What happens is that those people, they forget about the direction. They sit in the corridor and they start looking for where is my house. They enter into a neighbor's house, looking at that's near one. And that's another thing which happens in cognitive functions. The fourth is reasoning. The fourth is reasoning.
This third cognitive function, how we rate this person if he has with the
no, all these five of them, a person will have a progressive dementia and he will have impairment of all five.
But only one is there.
If only one is there, that will be memory. Memory will be the first of go.
But space is.
But if you are having a spatial disorientation, we should first check for vitamin B12 deficiency. We should check for alcoholic alcoholism. We should check for early dementia.
I come to across day before.
Yes. If there are people, see, if you see that classical Amitabh Bachchan's previous movies after the influence of alcohol, and then you stand, make him here, wherever you stand, he starts going there. That is classical spatial disorientation being seen in Amitabh Bachchan's movies after the influence of alcohol. And that's what cognitive dysfunction is. Alcohol is a cause of that. And then comes his reasoning. You will not be able to reason out why you are here today.
For the webcast.
For the webcast. That's the reasoning for the welfare of the society of the IMA. And then language is very important, is reading and speaking. And in the language, it is word finding.
Okay.
So for example, you say, oh, I can't remember. Uska naam kya tha? What was the name of that person? It's coming, it's coming, it's coming. And that's the second to go after memory. The first to go is
but once in a while
memory.
that happens to everybody. I
Yes,
suppose.
therefore that's called cognitive MCI, minimal cognitive impairment. But if that is progressive and it is impairing your day-to-day service, that becomes dementia. That becomes dementia. So therefore,
world is progressive, everything is
yes.
progressive.
So if I have to see two things, if I have to examine two things, is you start talking to the person and then ask him after 5 minutes, what did I teach you? He will not be able to tell. And then what finding? And the formula of 7 is very clear. I said 100 minus 7. Similarly, 7 is for the language. The 7 word, the number 7, SCVEN 7, is the most difficult to find. Okay, so you can give him, you can show him something and then say, what was this number? Word finding, specifically the word 7, is difficult to find. But most of the people have name difficulty. They will say, I can't remember. Uska naam kya tha? Mujhe yaad aa raha hai, mujhe yaad aa raha hai. And that's a minimal MCI, minimal cognitive impairment. So they have, in the elderly people, we need to have a minimal cognitive impairment, because if they have cognitive dysfunction, they need behavioral therapy, not CBT, not cognitive behavior therapy. In cognitive behavior therapy, the cognitive functions have to be normal. When the cognitive functions are normal, you give them cognitive therapy. And in behavioral therapy, the cognitive functions are impaired. And in CBT, you combine the two together. So in behavioral therapy is, for example, if a person is having dementia, okay, he has forgetfulness. So he will not remember where to keep his keys. So you give him mathematical calculations. You say, right side, this is the place for key. It cannot be anything else. So you predefine their places, predefine the times. Ghanti baji, 7 baja, chai aani chahiye. Otherwise they'll forget what is 7 o'clock and the time for tea. That is called behavioral therapy. You recondition people with dementia with that. So therefore, Forget Me Not is an international project. I like this idea. When I went to UK, I saw everywhere Forget Me Not wards, where people with dementia are being taken care of. And they are reminding you, forget me not. I am forgetting, but you shouldn't forget me. Because I am forgetful, but that does not mean you should be forgetful for me with that. So these are the 5 cognitive functions which needs to be taken care of. And apart from that, elderly depression is also common. And this is extremely common, elderly depression, which should not be missed in the elderly population. And otherwise, these are the people who sit in isolation. And so never miss elderly depression. The next thing comes is osteoporosis and vitamin D requirement. So, and that will talk about prevention of fall. Because if a person at the age of 70, 80 develops a fracture neck fever, he is gone. 50% of them will die in the first year.
Vitamin D is, I think, rampant all over the country.
So all elderly should be given vitamin D supplements,
yes,
calcium supplements, and dairy products.
Why this is happening? vitamin D and
See, in our sanskar, if you read the Vedic knowledge,
Exposure.
if you read the Vedas, our Rishi Muni has written one thing, that in a year, either in the month of Magh or Vaishakh or Kartik, for full month, you sit in the sunlight for 1 hour. So Magh Mela, Kartik Mela, Vaishakh Mela. People are supposed to go early in the morning, stay in the sun for 1 hour, come back and eat either urad ki dal or sesame seeds, both of them are calcium. So our ritual has been that once, that for 1 hour a day, for 30 consecutive days, you must sit in the sun and take calcium rich food. Therefore, being an Indian, we are prone to vitamin D deficiency. And therefore, Chhat Puja also came as that. All our festivals are linked to sunlight and calcium food. So therefore, kite flying was also calcium, was also vitamin D. So all our festivals have been. And why near the water? Because 40% of your body has to be exposed for 40 minutes, 40 days in a year, the formula of 40. And if I want to expose my 40% of my body, I can't do it at my residence. Joint family, a girl and a boy, none of them will be able to do that. But when you go to near the water, everybody is without clothes, so nobody looks at each other. So therefore, you will be able to get enough vitamin D. So in India, we are vitamin D deficient because we are not getting exposed. Therefore, we should take it.
इसके अलावा भी ये भी तो है ना कि
Genetically, we are prone.
नहीं जिस तरीके से अपना रहन सहन है,
Yes.
मकान कमरों में रहते हैं,
Same.
एसी वगैरह लगे हुए
Because
रहते
we are
हैं,
not-
सारे पर्दे वगैरह लगे हुए रहते
We
हैं,
are
exposed at all
our
because
body.
sunlight-
See, sunlight, even if I am exposed to sunlight, if it is through a glass window, I will not get vitamin D. And if it is not exposing 40% of my body, it will not give me enough vitamin D. So, next comes is multivitamins. Should an elderly patient get multivitamin dose? The consensus
There is a lot of controversy over it.
consensus is no need. But yes, you need supplements. That means if you have protein deficiency, you need them. If there is a deficiency of protein, because you need in any way 1 gram per kg body weight. And that much protein you don't get. Therefore, the need of supplements is definitely there in today's era, specifically vitamin D, folic acid, calcium, those supplements
But
needs to be taken.
I'm telling you, in my clinical practice, when I given one multivitamin capsule as a supplement to the elderly, they are clinically they feel much better.
So, therefore, I
They
said,
must be having some deficiency, it means.
So it is almost routine in my clinical practice was routine कि after this 60 to the senior give one multivitamin capsule.
the next is vision and hearing. They are very important. And in the vision, you know that a simple vision test is from an arm's length, you should be able to read a newspaper, the headlines of a newspaper. And if you can do that, you are fine. And the whisper test in hearing is also common. Somebody whispers you on your one of the ear, and you should be able to listen it from the other ear. So, and hearing in any way is the third most common disability after the age of 65. Therefore, you must tell your people, if a person, if he has a hearing loss, he must use it. He must use the hearing aid. Important thing comes is the fall and mobility. How do I know my patient is at risk of fall? Simple test. You can charge 500 rupees per test. It can make you a simple ethical earning. Is go up, go and come back. Get up. Stand from your chair. Then go for 10 feet. And then come back. And sit. It should be less than 15 seconds.
If he is able to do it.
If he's able to do it, less than 15 seconds, it's fine. If it is more than 15 seconds, he is at risk of a fall. And if he's at risk of a fall, ask him to use a stick for walking. So simple tests are available. You can go on our IMA website. We can give you all of them. We're going to release a small booklet on formulas on this Sunday, which talks about everything there. Then comes is the incontinence. Care of the incontinence is extremely important for both bowel and bladder incontinence. And now we are talking about elderly. You have napkins. You have not napkins. What you call them as diapers. So elderly diapers are now available. So make sure that you don't end up into incontinence of the stool, leading to problems in your skin, and of course with the retention of urine. And in the elderly, you have to also be careful about cough syrups and cold medicine which can precipitate prostatic retention. Any further advice or incontinence?
I'm telling you what are the simple measures. Okay, these are the things we have to take care. But what are the simple measures so that they himself will take care if something is happened to them?
Simple ischemial exercises, the pelvic exercises, all elderly should be told pelvic exercises, and if they must be examined for prostate enlargement, because you cannot allow any amount of retention in such cases to prevent infection. Now comes is the role of Viagra-like drugs in 60 plus. I'm not talking about 80 plus, but 60 plus, yes, most of the people would like to take an option for Viagra-like drugs. What advice you will give?
I think his coronary should be examined, ECG and things should be done. And if they are normal, then we can definitely allow them to use it.
So if the person can walk for 2 kilometers without any problem, climb 2 flights of stairs, absolutely he is safe to undergo any sexual activity. Important comes is only for those people who haven't had sex for the last 10 years or 15 years, and now they want to have, they have got a companion and now they want to use a Viagra-like drug, they need a checkup. But if they have been having sex with their partner all these years and now they are getting in difficulty, using a Viagra is not a problem as long as they are not on nitrates.
That's right.
As long as they are not on nitrates and their blood pressure is controlled, in such situations, using Viagra by a person who is 60 plus is absolutely safe with that. Polypharmacy. So be aware that polypharmacy is a problem. It can lead to delirium, it can cause sleepiness, it can excessive sleepiness. And when I talk about polypharmacy, it means more than 2 or 3 drugs. And the polypharmacy problem comes is because you have a separate gynecologist, separate orthopedician, separate dentist, separate cardiologist, and all of them are giving you painkillers for a different indication. And you end up into combining drugs which have side effects. So polypharmacy, anticipate polypharmacy. When you have a person who is older sold, always look for what other medicines he is taking, whether from this system or any other system of medicine. Now let me spend.
So anyone before prescribing any drug, he
should
usually asking ki what drugs you are taking.
90% of the time the survey is that we don't ask, and we have seen even in the hospital practice 4 different consultants seeing and 4 different painkillers given to the same patient. They don't even bother about what other painkiller is being given by other person. So we need to anticipate and prevent polypharmacy, because not preventing polypharmacy can be a professional misconduct in the
it is a disaster.
It's a disaster. It can be a professional misconduct in the. So we come back to the last session of the elderly care, and that's end of life issues. Advanced directives is very important. In India we do not have. Do not resuscitate, we do not have the concept. Advanced directive is that I can give directives in advance, write a will. It's like a will. And the third thing is that if I become unconscious, who takes care of me? So somebody has, I have to assign somebody, designated person who can look after me. So have you made your will?
Not as yet, I'm still young.
So when are you
Okay, but
when you are young, then okay.
When I get 70 years old.
When you are having dementia, then will not be of value. Somebody will challenge it that you are not in your normal senses.
You're right. I think what is the suggested age for that? 60, 70?
Even 20. Every year you change. Will has to be made at any age. You have a will, and every year you can change. You can say update.
The accident, anytime.
See, will, everybody should have their will, and then you can update it every year on your birthday. You say, let my will there. You says continue city hall. Like you go to your hospital, you says continue same treatment. Similarly says city hall. You sign.
Continue like that.
Okay. What do you mean by will? Will is your wealth. Definition of wealth is not money. आपकी इज्जत, आपकी शोहरत, सब कुछ है. ये सब आप बांटने जा रहे हो. So therefore, writing a will involves your wishes, your action which gives you inner happiness, your wealth, and then
The family responsibility.
family responsibility and your own responsibilities. And I always suggest make a family will, you make a family trust to look after. Say for example,
ये
my father's died, and now I'm converting into a family trust, where the money out of the interest of that will be taken care of only those people who are 80 plus. So that there is a family trust available, where there is a pool, money lying in the pool, and the interest of that can only be used by your progeny for generations together, only for the people who are 80 plus.
Now it
So
is
it
by
can be
your,
anything.
it is by your
Choice.
decision or by
Choice.
your father's will.
मैं
It's all a collective decision of all of us
Of the
together.
family. Yes. Okay.
केके जो अपने पहले जॉइंट फैमिली थी, जब तक जॉइंट फैमिली अपने यहाँ थी, इसीलिए ये अभी तक विल का पूरा ठीक है कि ओनली द 5% ऑफ द पॉपुलेशन जो है वो इसके बारे में अवेयर और वो समझती है, नॉट मोर देन दिस, जो अभी सर्वे हुआ था। जो अपने जॉइंट फैमिली था वो इसका आंसर था कि उसके कारण जॉइंट फैमिली का जो हेड होता था वो या तो नीचे का कोई चले जाता था तो वो डिसाइड करता था, अदरवाइज जॉइंट फैमिली से जो हेड होता था उसके बाद में जो हेड बनता था वो ऑटोमेटिक जो है ना इज्जत, शोहरत, चीज़ें, वेल्थ, वो सारी की सारी उसके अंदर होती थी। और वही जॉइंट फैमिली जो है ना वो इंश्योरेंस था,
पकड़ी इसको।
हाँ इंश्योरेंस था। मैं कह रहा हूँ वही जॉइंट फैमिली जो है वो किसी भी परिवार के अंदर कुछ भी मिस्चीफ हो जाए या कुछ भी हो जाए तो वो इंश्योरेंस था। वो सब चीज़ें अपने यहाँ चली गई, तो उसके बाद ये सब चीज़ें हुई हैं कि जॉइंट फैमिली से न्यूक्लियर फैमिली से अब इंडिविजुअल। अगर ये सब चीज़ें आज अपन ये देख रहे हैं कि पूरे वर्ल्ड के अंदर जिस प्रकार से वापस फैमिली को लाने के लिए और उसके लिए चल रही हैं, तो फैमिली और परिवार और विवाह, मैरिज, ये दो जो इंस्टीट्यूशन इंडिया की ये दो इंस्टीट्यूशन थी जिसके कारण की पूरी संस्कृति जो अलग से है भारतीय संस्कृति, वो केवल इन दो इंस्टीट्यूशन के कारण।
It's a big question in the family.
So let's have the last 5 minutes with us. We will definitely like IMA is writing to the government to have IMA's suggestions on government policy for the elderly care, to build up low-cost old age homes, to train all over the country the standard treatment guidelines as far as the elderly care is concerned. We are also writing to MCI and the DNB board to have geriatric medicine, lots of more courses. We also will be developing some of the courses with that. And of course, longevity is an issue, and one should live every day of your life. That's the most important thing, is that whatever day you live every day of your life, whether it is 60, 70, 80, 90, or 100, but always aim for 100. If somebody asks me what's my age, I would not say 57, I would say 43, because my aim is 100. Age is what is left, not what age which is lived. And in the last 5 minutes, I want to divert the whole issue. What is that? When I talk about end of life issues, what is death and what is life after death?
I think we should be able to tell better. And in fact, we must share with the audience also that KK has lost his father at when he was 97 years of age. So he can tell us more about the way to age gracefully, and then what after.
See, if I really want to age gracefully, the only answer is that live every day of your life and aim at 100. And instead of saying that I am 60-year-old, you say 40 to go. Always be positive, in a positive state of mind and live, and then only you will be able to achieve. But sometimes I would definitely like to have a debate on this issue, because many people ask us about karmas, about prarabdha karma, about sanchit karma, about agami karmas, about vakvritti, manovritti. They talk about pranvritti. They talk about is there a soul, what happens to the soul after the body. And our answer is we don't know. Our answer in modern system of medicine is we don't believe in rebirth, we don't believe in, but we do believe in death, but we don't have any definition of soul. We do talk about consciousness. But let me tell you, if I really want to summarize it in 2 to 3 minutes, death is reversible. Death is not an instantaneous process. The first to die is our karmendriyas, and amongst the karmendriya, the last to die is the hearing, and that is called vakvritti. A portion of the vakvritti gets frozen, called vakvritti, then it merges into manovritti. Manovritti is 5 indriyas, jnanendriyas, along with mind, intellect, memory, and ego. And a portion of that gets frozen called manovritti. And amongst manovritti, the last to go is speaking. So the first to go is the first to go is speaking, the next to go is hearing, and the third to go is pran, called pranavritti. And then it merges with a layer of tej, that is your metabolism in the body, and then you enter into sat, called consciousness, or you die. So therefore there are stages of death. Therefore tej, if the tej is not there, you are not dead. And that's the reason of therapeutic hypothermia. That at the level of your karmendriya, vakvritti and manovritti and pranavritti, that means your indriyas have gone, your hearing has gone, you cannot speak, your respiration has stopped, your heart has stopped, but the body temperature is not adequate for the consciousness to go out. You can freeze your consciousness there by therapeutic hypothermia, like what you do, your ova you are freezing, sperms you are freezing. So if you preserve the body at that particular stage, the consciousness will stay there, and you can call an advanced team who can come and give an electric shock and then try to revive the person. So that is not an instantaneous process. Lots of work is now coming, where I give you an example. I got a call from a lawyer from UK, and he says, my father has died, take a flight, come back and revive him. I said, what do you mean? I said, where is he? He says, in the freezer. I've kept him at -20, freezer. So I said, how long, what time you kept? She said, after half an hour of death. I said, nothing can be done. I said, if you have a cardiac arrest and if you freeze the body, theoretically, there are instances you will be able to revive the person. So death is not an instantaneous process. Death is vakvritti followed by manovritti, manovritti followed by pranvritti, pranvritti merges with tej and tej with sat. And that's what the Upanishad definition of the process of death is, which is now being validated by the medical profession with that. Now what happens to the body after that? Once this vritti goes, which becomes prarabdha karmas, it goes where? Now there is a debate. Somebody says you cannot come back, somebody says you come back. And those people who believe that it comes back, it goes to, this information goes to the cloud, there it gets energized, called potential, then comes back and eaten by the plants, taken by the plants. And therefore you say, वो खेत में मिलेगा, खनियाल में मिलेगा, भगवान तुझे बंदे इंसान में मिलेगा. You never say, वो कुत्ते में मिलेगा, बिल्ली में मिलेगा, भगवान तुझे बंदे इंसान में मिलेगा. So the Vedic knowledge says that me and my plant have the same consciousness, and that same consciousness, till it comes back to my potential parents, will stay in the plants. And from the plants, when we take fruits and vegetables, it comes back to us. So fruits and vegetables contain, therefore you say, you take fresh fruits and vegetables because it contains the same consciousness, and that same consciousness gets transferred to me. We may not believe, as an allopathic doctor, we will not believe that. But
जैसा
अन्न वैसा मन. So therefore it comes back to that, and that gets transferred to my body through that. And then when I eat, what does it make? It depends upon what I am eating, the fat, the solid portion or the water portion. When I take the liquid portion, the crudest part will make the urine, the subtle part will make the prana, and the middle part will make the blood. Similarly, when I eat the fat, the subtle part will make the bone, the middle part will make the bone marrow, okay? And then similarly, the flesh will be made by the solid part, and the feces will be made by the solid part. So similarly, the whole body, how it mixes up is typically described in Vedic language. But the only lesson we need to learn is A, plan your old age. Plan your old age. Now, if I don't have money, what should I do? Suppose I am an elderly person, I own a house, but I have no source of income. My child doesn't want to give me my monthly maintenance. What do? Reverse mortgage your property. Reverse mortgage your property, which every doctor must know, is that suppose my property today costs 1 crore. I can give it to the bank. Okay, the bank will give me, say, I can ask for 1 lakh a month. The bank will start giving me 1 lakh a month till I die. The property will remain to the bank. At the time of my death, the bank will say, okay, I've given you 20 lakhs. Within interest, it comes out to 30 lakhs. Then he will come back to the children, the owners, and said that if you want this property to be released, give us 30 lakhs. This property is yours. Otherwise, we are going to sell this property, and the rest 70 lakhs we are going to distribute to you according to the will of the person. That is called reverse mortgage. In reverse mortgage, you don't have to pay the installment. So every doctor who is listening here and is practicing elderly care must know the concept of reverse mortgage. And I have helped not less than 15-20 people like that myself. And reverse mortgage is a phenomenon, is a scheme which is brought by the government of India to look after the elderly care. Your own property you can mortgage, and bank will give you interest-free installments till you die. And whatever is left will be distributed to your children. So therefore, nobody should say, I am an elderly person, I can't afford. If he owns a house, he can afford. And if he can't, things are different. Then he can go back to his children for his right to the High Court. He says, I looked after him till he was 18. He's supposed to look after me for the last 18 years. He's not doing that. Then the High Court can intervene and ask the children, they can direct.
अभी बन गया ना, ये तो कानून भी आ गया है, एक्ट आ गया है, एल्डरली का
Yes,
केयर का,
absolutely.
एल्डरली केयर का जो है वो आ चुका है.
So this bend your.
कर सकते हैं.
I think everybody should understand at his age, at your age, at my age, that our elders are the rover. We should take care of them, and then our children will be able to take care of us. If we don't take care of them, then nobody else will do it for us.
So that's all for today. The time is up, and we did try to talk about some of the elderly issues. We hope to debate this, and we will have lots of discussions during the years on elderly care, because one of our focus will be on elderly care. We'll be back next week with some more topic till that. Goodbye. Thank you. Long live IMA.